Welcome to GatewayC Live, fast facts supporting earlier and faster cancer diagnosis. Breast pain. Think breast. Our specialist is Professor John Robertson. B. Breast pain.
Breast pain is a very common benign condition of the breast that affects between 50 and 80% of women at some point in their life. There are two main types. Approximately half is not coming from the breast itself, but from the muscle underlying or the ribs underlying. We call that skeletal muscular etiology. The other half is coming from the breast tissue and can be either cyclical, associated with the menstrual cycle, or non-cyclical. But it's a benign condition. They don't need investigation for breast pain only. As I said, if they've got some other condition, they may be referred for that, but for breast pain only, they do not need to be investigated for the pain as such. Breast pain is not associated with breast cancer. And I think that's clear from both the literature, if you review it, but also to the NHS has stated that in its most recent guidance actually stated that patients with breast pain do not need an urgent referral to the secondary breast units because breast pain is not associated with breast cancer.
R. Red flags.
Establish first of all that it's breast pain only. If they've got another breast symptom, they may need to refer to the 2-week wait for that alone, not for the pain.
E. Examine.
If it is breast pain only, then to examine the patient. Firstly, you should examine the patient sitting approximately 45 degrees, flat of the hand, examining all areas of the breast and also the drainage, lymph node drainage areas. If you think it's coming from the muscle or the ribs underlying, I tend to lie them on their side, tilt them over on their side so you can expose the muscle and the ribs and then press directly in those to see is that where the cause of the pain is located.
A. Ask about family history.
Next thing to do would be to take a familial history and to see are they increased risk of breast cancer? Are they what we call near population risk, in which case they don't need to be referred, or do they fall into a moderate and high risk category where they should be referred to the local familial cancer services which are appropriate for the local pathway.
S. Screening breast.
I think you should take the opportunity of discussing screening with all women, whether they get breast pain or not. If they're under 50, they need a family history assessment to see should they be referred for screening because of increased risk. If they're over 50, they fall into the NHS breast screening programme and they should be given advice about that and advised to go along. But that's for any woman, not particularly because they've got breast pain, but we should take the opportunity.
T. Treatment.
And it's usually 3 months of treatment by the general practitioner, and if it doesn't then settle or there's ongoing problems, they could be referred. As I said, there's guidelines, and usually most GPs already look after patients for around 3 months. There are pain ladders, so they can go through a whole list of treatments. If they're going to refer, in the past they had to almost refer to secondary breast care units. I'm pleased to say that there's now an initiative within the NHS to actually establish community specialist breast pain clinics, and women can be referred there. It's a joint primary care, secondary care initiative. It's being held in primary care, those clinics, and they can be referred there for more specialist assessment and treatment of the breast pain. Breast pain is not associated with breast cancer, and therefore don't heighten a woman's anxiety about breast cancer when she presents with only breast pain.
Breast pain. Think breast. B. Breast pain. R. Red flags. E. Examine. A. Ask about family history. S. Screening breast. T. Treatment. Fast facts supporting earlier and faster cancer diagnosis.